Thank you very much, madam. First of all, I would like to thank the Endocrine Society, the office bearers, Dr. Ganpati, Dr. Kalra for helping us arrange this seminar on rare forms of diabetes. I have specifically to thank Dr. Jindal and Dr. Mohan for helping me in the preparation of this presentation. As you can see from my CV, there are not many publications there. So the only reason I'm speaking here is probably I've got friends in the right places, and probably due to my mustaches and phenotypic mustaches and long nose, it was mandated by ESI that I be allowed to speak. But what has now been in the past three talks, we've seen that probably when you pay attention to the patient's presentation, his characteristics, his phenotype, and his family history, you probably get to know what is the probable cause of the diabetes. And more so, it is very important in MODY. Otherwise, you will be sailing in uncharted sea. MODY is not very rare, as I came across several publications from India, especially from Dr. Mohan's group. The only thing is probably we've not looked that well, not looked that closely. When I was given this topic and I was doing the literature search, again, being held by Dr. V. Mohan and Dr. Jindal, I searched for MODY diabetes, and the next what comes to mind is that you have MODY there. It also comes in related searches when you look for MODY diabetes India. So this formed a new reference point from where I thought I'll start my lecture. Now, there is a phrase where we all say that MODY hai to mumkin hai. That is, when there is MODY, it is possible. Now, I have few statements like, when it is MODY, it is possible to stop insulin and maybe give a small amount of sulfonylurea. When it is MODY, it is probably possible to stop treatment altogether. When it is MODY, you can actually predict or prognosticate diabetes in other family members because of the penetrance of certain genes. When it is MODY, the patient can have neonatal hyperinsulinemic hypoglycemia and then later on present with diabetes. When there is MODY, you can have patients with extra-pancreatic problems in renals, and which is known as the RCAD diabetes. And then if you dream big, and then if you sufficiently follow up your dreams with actions with full conviction, you may even be invited to give TED Talks for diabetes, as Dr. V. Mohan. Dr. Hari, in his presentation, quoted Dr. Mohan's study and his group many number of times. And when we talk about MODY, I think we will be doing the same here. The terminology MODY was coined by Tattersall and Fajans in 1975. And when I was doing the literature search, I came across the first paper from Dr. Mohan in 1985, when there were no genetic studies on MODY, and it was all clinical. And after having read that paper, I felt that MODY diagnosis and prognostication and how you manage it probably is again a lot to do with how you sit and examine a patient and take the history properly. I am guilty of probably missing out on a lot of MODY patients. And then when I prepared for this talk, then I came across so many more cases which I thought probably could have been MODY cases. Now, in the 200th year of NEJM, they brought out an anniversary issue and they talked about precision diabetes management. So in precision diabetes management, as Dr. Jindal initially stated, that you have genotypic phenotypic correlation. And that is so true for MODY, because some of the cases, when you diagnose genetically, you can actually pinpoint what best medicines to give to that patient. Now, coming on to diabetes of the young, it is like a chameleon. And you actually don't understand initially when the child presents to you or the young adult presents to you with diabetes, more so in India. After having reviewed many papers on MODY in the Western for Caucasians, they also put in a line, because a lot of Indians have settled in UK, who were involved in studies for MODY or young diabetics, those in South Africa, and even in the US, because they always say that probably one of the things which complicates matter is the young onset of type 2 diabetes in Indians. Some Indians don't have obesity to present with. Some young adults don't have obesity when they present, but although we know that obesity is diagnosed at a lesser BMI in Indians than in the Western population. And of course, family history is so widely there in all our young adults who present with diabetes. So basically, unless you look for MODY, you will not find it. So, and another good thing which has happened over time is that they have stopped as 1-2 ka 4 and 4-2 ka 1, in which that they have stopped numbering them as MODY 1, 2, 3. Now they label it as an HNF1 alpha MODY and HNF4 alpha or glucokinase GCK MODY. So that is good. That has taken away the burden of remembering all those numbers. Now, when I was preparing for this lecture, I then sat back and thought that after having practiced for so many years, why haven't I sent patients for genetic analysis? Although there must have been so many cases which we would have seen. The exact incidence probably we would not know, because we don't have a pan-India study for MODY. As it is said that eyes do not see what the mind does not know or look. So that is important. Then, we usually do C-peptide in all our young adults or children who present with even diabetes. But we also know that initially and in the honeymoon phase, the C-peptide can be high in type 1s as well. So what I have started, if there is one slide which you should remember of this whole presentation, it should be this. Because when the patient presents to you, the only history which we take is parents' history, and then we don't go another generation. So what we should be doing is charting out a proper family tree, presentation of diabetes, ketotic, non-ketotic, age of onset, acanthosis, and of course the anthropometry. That should put us on a course where we can actually rule in or rule out several forms of diabetes in the young. So monogenic diabetes, I forgot to say that it is the commonest monogenic diabetes is MODY. Then you have the neonatal diabetes, and then you have maternally inherited diabetes and deafness, which is a mitochondrial form of diabetes. Now, what are the characteristics? So this is basically from the JCM article 2021, just published. The children and those diagnosed in early adulthood who have diabetes, not characteristics of type 1 or type 2, which have an autosomal dominant inheritance. Age of onset can be less than 35 or less than 25. So here I put an asterisk, because yes, in Indians, you can have type 2s presenting as 13 years and 14 years. There could be a history of neonatal hypoglycemia. And I would be also discussing about glucokinase MODY, where the lady can present with gestational diabetes and the child may have macrosomia. So you may actually miss out on MODY in a pregnant lady. So neonatal hypoglycemia, we may think will be due to the lots of insulin used, and progressively and post delivery, the child goes into recurrent hypoglycemic episodes. So that has to be kept in mind. Importantly, they are antibody negative. So I was just wondering, why does MODY, which is HNF4 alpha MODY, have hypoglycemia at birth and hyperglycemia later on? Because the number of beta cells are increased in the prenatal period and at birth, and then there is a progressive beta cell loss due to apoptosis. What else characterizes MODY is the low insulin requirement. So if you have some of your patients who have presented young, have very low insulin requirement, not in the honeymoon phase, after the honeymoon phase, then you should think of MODY and probably do a C-peptide in them. So what is the C-peptide level? What has been mentioned is 0.6 nanogram per ml with a blood sugar of 72 milligrams per deciliter, so that you don't measure it during a hypoglycemic episode in one of your child. Lack of ketosis when insulin is omitted. When the child omits insulin inadvertently, the child comes to your clinic and says, "Do din se insulin nahi lagaya," think it could be MODY. Then you can have patients who have extra pancreatic features, renal, GI, and then you can have they leading up to nephropathy and requiring renal replacement therapy. Subtle features which probably for us will be difficult to find out. Normal TG, normal or elevated HDL is seen in HNF1 alpha MODY. Indians usually have a high TG and a low normal HDL. So in glucokinase, you can have mild, stable fasting hyperglycemia, which is non-progressive, and which responds appreciably to pharmacological therapy. As the chairperson had stated, they're exquisitely sensitive to sulfonylureas. Family history, we've already spoken. But in type 1, although we know it is sporadic, but 2 to 6% can have parents affected. Type 2, it contrasts as age of onset, but in India, as I stated, the age of onset is so early that you may still not use it as a criteria. Usually type 2 kids are obese, or young adults with type 2 are obese, but 4.5% of MODY may be obese. One cause of obesity people think would be insulin-induced obesity, and also I thought it could be defensive snacking, because the children may eat a lot because of recurrent hypoglycemia. So defensive snacking can also lead to obesity. Now, prevalence and gene mutation. So we know that majority of MODY cases will have either the transcription factors like HNF1 alpha, glucokinase, and HNF4 alpha. Interestingly, I came across a paper which talked about penetrance. Now, when you read about HNF1 alpha, it is so penetrant in family that approximately 63% will be diabetic by 25 years, 80% diabetic by 35 years. So it is not that if somebody presents to you with 36 years of presentation of diabetes, the patient cannot have MODY. So you have to keep your eyes and ears open and always draw a family tree when somebody presents with diabetes. And of course, there are rare forms of diabetes, but one to mention is HNF1 beta, which again, which is MODY 5 and associated with the renal disease and urogenital tract abnormalities. So this is an algorithm, again, from the JCM paper. So history, physical examination, 3-generation family. Then if you feel there are clinical characteristics, no acanthosis, not obese, no ketosis, then they say do GAD antibodies, islet cell antibodies, and zinc antibodies. But then we know that there is cost constraint. I think if somebody wants to do, so only a GAD antibody, autoantibody would be good. And then supportive tests. Now this again is important. As I mentioned, outside the honeymoon period, a fasting C-peptide of more than 0.6. They also state about highly sensitive C-reactive protein, which I don't think is very important. But a very good thing which they mentioned is a 2-hour postprandial urinary C-peptide to creatinine ratio. That is after your largest meal, which is more than 0.2 nanomoles per millimoles. That is a good criteria. And it is 97% sensitive and 96% specific. Now, there is a risk calculator also, which I tried putting some of my patients, and in which if there is a more than 25% probability, then you should go in for a genetic testing. and then you order for molecular testing. Now, molecular testing could be, you have three options. If you are almost certain, or if somebody in the family is already diagnosed case of MODY, then you could do a single gene testing, where you use specific, you test specific genes. In option 2 would be do a multi-gene panels. A lot of companies are coming with all known 14 genes so that they pick up the known genes. And then the option 3 is like finding a needle in the haystack, where you are not sure, but the clinical characteristic, the C-peptide fits, then you do the exome sequencing. We definitely know that Dr. Mohan is doing it, and I'm sure some of the labs who do in genetics, deal with genetic analysis, would be doing it. I do not know the cost as of now, but there is a diabetes care paper who states in UK at least, doing a genetic analysis is cost effective. Therapy wise, as I stated, they're exquisitely sensitive to sulfonylureas because there is preserved beta cell function. A low dose sulfonylurea would help. But in HNF4 alpha, there is progressive beta cell loss to the tune of 1 to 4% per year. They may require insulin. Eventually, all patients may require insulin. Other drugs which have been used is GLP-1 agonists, DPP-4 inhibitors, SGLT2 inhibitors. But then there are case reports, as with type 1s, that they can have euglycemic ketosis. The good part about glucokinase MODY is that it does not require treatment because on follow-up, up to 50 years follow-up, they don't have complications which are seen in diabetics. The complication rate is similar to the general population. So it is that you don't need to treat it. But a very, very intriguing point which I found out, and just yesterday night, one of the gynecologist friends rang up that one patient which we had diagnosed with gestational diabetes, managed only with diet and exercise. She felt that the child is now macrosomic and we do not know the cause. And then I was reading about glucokinase articles. Now, what happens is, if the mother has glucokinase mutation, MODY, the lady presents, now since we are testing all of our pregnant women, there is a universal screening, she presents with gestational diabetes. And if the child, if the fetus does not have the mutation, so the maternal hyperglycemia causes macrosomia in the fetus, and the child becomes large and leads to complications. Whereas if the child is having the same mutation as the mother, the child is small for gestation age. So what you need to do is to start doing fortnightly scans in these women every 26 from 26 weeks onwards, and with the fetal abdominal circumference more than 75th percentile, start insulin and deliver early. And the insulin requirement in these women is very, very high. In the third trimester, it reaches up to 0.8 units per kg. So this has to be kept in mind, because we might have lots of women, although we all test blood sugars in the first trimester onwards, because we can unmask pre-existing diabetes or pre-gestational diabetes. But if somebody is doing after 20th week and diagnosis as gestational diabetes, one has to keep in mind, if the child becomes macrosomic, keep GSK mutation in mind. So complications, you have to be very, very vigilant, because MODY, both HNF1 alpha and 4 can have complications. Now, this is an interesting case. When I was reading the JCM article and other articles, they don't see probably type 2s as very old. This 11-year-old child presented with type 2 diabetes with an A1C type 2, because I'll just tell you why I was saying type 2 diabetes. A1C of 11, fasting post-meal high, triglyceride of 1000. And then she had a family history which was there. And unfortunately, I don't remember, I don't have the paper, who all was involved. She had acanthosis, no ketosis at onset, and she had a relatively preserved C-peptide. Although we know that with the caveat that C-peptide may be high initially, but then this child had very high, and she had no ketosis at onset. So we see a lot more young children, young adults having type 2 diabetes. So now coming back to the original statements which I make, we will all agree that if you have type MODY, you can stop insulin tight SU. So that becomes more important to diagnose and maybe do a genetic analysis, because you can wean off insulin in some of your patients. You can stop treatment altogether. If it is MODY 2, you can stop, that is glucokinase. Then you can predict another, as we saw the penetrance in HNF1 alpha, up to 80% have diabetes by the age of early 40s. There is neonatal hyperinsulinemic hypoglycemia, pancreatic renal abnormalities. So all this we can predict renal function, renal dysfunctions. And I will end this is my last slide, that unless the physician takes care, he will fall into schematic ways and forget that the patient comes for treatment, not the diabetes, and each case unto himself. And I also got a very good quotation from Charak, and I think like 3,000 years back, he said, if the physician then doesn't enter the patient with a light of knowledge about all factors causing the problem, he will then lead to abnormal diagnosis and poor management. So I think I will end my talk here. I'll be happy to take questions. Thank you so much.